We are back with the EPIRESEHA Insights and Perspectives on Viral Respiratory Infections. And the first speaker is Francesco Marchesi, one of the, like the other speakers, key contributors to EPIRESEHA, one of the motors of EPIRESEHA. And please, Francesco, start again.
Thank you, Gordon and Oliver, for the invitation, despite the technical problems, if you want to call them so. Okay, so I restart from the first slide. Today I'm going to talk about flu in hematologic malignant patients, data from our registry. As I said to you before, the registry came up as EPICOVIDIA, a registry at the beginning of pandemic, of COVID-19 pandemic, then turning to EPIFLU and finally EPIRESEHA. And that's because since 2023, the registry was expanded, incorporating in its scope other CAR-V. So basically, not just the SARS-CoV-2, but also flu, RSV, rhinovirus, paraflu, metapneumo, and other respiratory viruses. We included in our registry patients with active hematologic malignancies at any stage or status, patients, adult patients, so aged 18 years old or more. And we just excluded patients with hematologic diseases other than malignancies and patients off treatment for more than 5 years. That's how the registry works. Just a reminder for everybody. Basically, a new contributor can insert data in our web-based registry on clinicalsurvey.net, inserting demographic data, data about the underlying comorbidities, of course, data about hematologic malignancy itself, data about infections, respiratory infections, and about clinical outcome. All of it takes, I guess, 20 minutes or no more. And after, there is a pretty important validation process carried out from John and an hematologist or an ED specialist. And that's pretty important because of it's a guarantee of data accuracy and completeness. And so that's possible to define a case as a valid case and using it for authorship and manuscript preparation. Our registry, I'm talking about data collecting from January 2020 and August 2024. In this timeline friendship, we collected more than 12,000 cases. But if you take a look to the friendship between September 2023 and March 2024, we collected 1,312 CAR-V valid cases, collecting from 61 centers in 24 countries, basically in Europe, but also some countries outside the European borders. And if you take a look to the data, we collected 250 cases of flu in hematologic malignancy patients, counting in about 19% of cases. And that's the first points for debating. So how do we do a diagnosis of CAR-V in hematologic malignancy patients? A CAR-V diagnosis panel should be delivered to all hematologic patients with respiratory tract infectious disease. And if so, what panel is currently recommended? And that panel is available among all the hematology institutes, and it is available in all the European countries. And we also should consider all those hematologic malignancies patients easily manageable by general practitioners, so not referring to an hematology institute. So what about these patients? Some answer to these questions came from the new guidelines of SEL10, just published I guess a couple of months ago in Lancet Infectious Disease. And the guidelines clearly stated that for all patients with respiratory tract infectious disease admitted to the hospital or already admitted, we should deliver to them a comprehensive diagnostic PCR-based panel, including flu A and B, SARS-CoV-2, RSV, paraflu and metapneumo and others. So that's a pretty strong grade of recommendation. So we should deliver to all hematologic malignancies patients admitted to the hospital a panel like this. What about underlying malignancies? Over 250 patients with flu, just half of patients had a diagnosis of lymphoma and multiple myeloma. But we also have had 23% of patients affected by acute myeloid leukemia and an interesting number of patients affected by myelodysplastic syndromes, about 9%, and the CLL about 7%. What about characteristics of those patients at baseline? Let's take a look to the, Okay, let's take a look to the baseline characteristics. The median age was 64. 30% of patients were affected by 2 or more comorbidities. We see that neutropenia wasn't so important factor because just 9% of patients were neutropenic at the time of infection onset, and about 15 patients were affected by lymphopenia at infection onset. Just about half of patients had an active malignancy at infection onset, and I think the most important data of this table is what I underlined in red, because the vaccination rate at infection onset was pretty low, in my opinion, about 17%, with a median days from vaccination to infection of about 70 days. And that's the point for debating again. Why was the vaccination rate so limited? There was maybe a safety concern from the physicians, or maybe scheduling conflicts with chemo program, or just a lack of awareness of vaccine hesitancy. I think in any case, we should focus on improving education and redefining vaccine protocols here for improving the number of patients got vaccinated for flu affected by hematologic malignancy. And that's absolutely in line with the last HASIL 10 guidelines. That actually state and clearly state, as you can see from the arrow, that annual seasonal administration of vaccine is recommended at the beginning of flu season in all hematologic patients. And that's a pretty strong recommendation, A2. And we can also extend this recommendation for patients undergoing autologous or allogeneic hematopoietic stem cell transplant. What was the last ongoing treatment for our patients? As you can expect, the vast majority of them were receiving immunochemo at the time of onset infection, 32%, and that's quite understandable if you think about the distribution of the disease, and the majority of those patients were affected by lymphoproliferative disorders, and so it's quite understandable that the most relevant treatment, ongoing treatment, was immunochemo. What about influenza severity and treatment? As you can see from the graph, the vast majority of cases were defined as mild, but we also have a quite remarkable number of patients presenting with a severe influenza or critical influenza, 12%. And that's really, really interesting, maybe a little bit overestimated, because as I mentioned you before, we don't see the portion of patients basically asymptomatic or just with fever, easily manageable at home by maybe general practitioners. But it's anyway remarkable that 12% of our series presented as critical infection at the time of infection onset. What about treatment? If you have 70% not receiving any treatment, It's also interesting to underline that the majority of patients, about 80%, received antivirals alone or combined with steroids. None of those patients received immunoglobulins, and we also had 3.7% of patients treated with steroids, just steroids only. And that's absolutely in line with the new ICD-10 guidelines that clearly state that the first antiviral treatment is based on oseltamivir with a dosage of 75 milligrams twice per day for 5 to 10 days. Just take a look to the outcomes. The first outcome we took a look was admission rate. And so the admission rate was really, really high, 65% overall, with 12% of patients, as you mentioned before, admitted in ICU at the beginning of infection. These data are slightly higher than the SARS-CoV-2 and quite comparable to paraflu and metapneumo, and it is really, really remarkable that 12 patients affected by influenza and hematologic malignancies patients were admitted in ICU. What about secondary infection? Overall, we found a rate of secondary infection of about 15%. Mostly of them bacterial infection, but we also see 5% of patients affected by secondary fungal infection, and that's expected if you know that a well-known nosocomial entity is flu-associated pulmonary aspergillosis. And finally, we're gonna take a look to survival. As you can see here, we observed a 30-day overall mortality rate in our case series of 8.8%. And if you wanna talk about attributable mortality, this percentage drops to 7%, 7.2% exactly. What about risk factors for mortality? As you can see here, both in univariable and multivariable analysis, lymphocytes count higher than 200 is a protective factor for survival. And on the contrary, developing a secondary bacterial infection is independently associated with a high risk of mortality with another ratio of about 10. So my conclusions are basically that influenza is the second most common respiratory viruses infection in hematologic malignancy patients. Even if our registry does not provide any data about incidence because we don't have basically a denominator, but a quite understandable data about prevalence. Influenza is related to high morbidity rate with an admission rate in ICU of 12% in hematologic malignancy patients. Attributable mortality was of 7.2%, maybe a little bit overestimated for the reason I told you before, but even and despite that, absolutely remarkable. Lymphopenia and the secondary bacterial infection were independently associated with a higher risk of mortality. And I think the most important conclusion of our registry is that vaccination policy and diagnosis procedures need to be improved in hematologic malignancy patients in order to improve the clinical outcome of those patients. Thank you for your attention, and I am open for the questions just right now or at the end of the presentations.
Thank you, Francesco. Very, very nice, very interesting data. Of course, I just arrived at a question that is quite complicated to give a reply. What can we do to increase the vaccination rates?
I think a vaccine education should be the most important thing for improving the rate. So even especially the hematologists, I don't think they actually believe in vaccination. And so the first step, I think, should be a training for hematologists and general practitioners. General practitioners sometimes, at least in Italy, are afraid of hematologic malignancy patients, demanding all the decisions to hematologists. And in some cases, I guess the hematologists are not so aware of the importance of vaccine in our patients.
And another question that arrived that is very interesting because, as you know, sometimes there is a suggestion mainly in lymphoproliferative disorders to perform two doses of a vaccine with a booster after 2-3 weeks. A colleague asked if there are indications for twice in a year or doses of a vaccine.
Actually, I don't think so, but I don't think there is a specific indication, but I think could be a right approach, especially for patients receiving anti-CD20 monoclonal antibodies, in which we expect a low rate of response to vaccine. So should be a rational approach in those patients, I guess.
And this is my question for you. When we must perform the vaccination? The main problem is, for an example, for patients with an acute leukemia or myelodysplastic syndrome of chronic lymphocytic leukemia that, of course, have mainly thus too have a chronic treatment. There is no, we cannot give the vaccination before start the treatment, but usually they are a long treatment. There is a contraindication when we must perform, in example, in myelodysplastic syndrome, the vaccination at the
I
time
think
correct or not, please.
I think I still can clarify this aspect. So at the beginning of the flu season for chronic patients, as for acute myeloid leukemia patient, you don't have time because you need to start treatment. I guess at the first complete remission could be great window for performing the vaccine. But a diagnosis of disease is almost impossible because you need to admit in the hospital the patient and start the induction treatment. So after achieving a first complete remission is the best timeline for acute myeloid leukemia, in my opinion.
Another question that arrived from the colleague is, how do you vaccinate after autologous transplantation for multiple myeloma? If the patients need to continue data-based maintenance for some reason?
So the indication of FSL10 is for the patients to get vaccinated after 3 or 4 months after the transplant, even if they are continuing consolidation with daratumumab. There is room for vaccination. You don't expect a high probability of response, but I think it's worth it to try.
But we must wait a time from the rituximab administration in lymphoma before vaccination, or there is no difference.
If you can perform the vaccine just after rituximab starting is the best option, of course. If not, you should wait 6 months after the last rituximab dose because of the lymphopenia. Basically, takes 6 months to be resolved after anti-CD20 monoclonal antibodies treatment. So if you can, you should wait for 6 months from the last treatment dose.
Perfect. Thank you. Don't go away because probably we arrive at the end of the presentation. Other question for you. Thank you, Francesco.
Thank you. I'm here.
And now the next speakers that I am really happy to present is John Salmanton-García, Spanish language, that a good friend, is a postdoctoral researcher in the Institute of Translational Research at the University of Cologne. John will speak about respiratory syncytial viruses, our experience of the registry and all the information that you need. Please, John.
Okay. Thank you very much for the nice introduction. I will start sharing my screen. Okay, can you see it now?
Perfect.
Okay.
Yes.
Yeah, thank you very much. So, well, I mean, since Francesco already spoke about EPIRESEHA, and basically most of the data in my presentation are also using that source, the now EPIRESEHA registry. I won't really go much farther into it. But I will start directly with some incidence rates for RSV. I mean, if you had realized in the slide set of Francesco, he was mentioning how in EPIRESEHA we had first SARS-CoV-2, afterwards influenza, and then there were died RSV and rhinovirus. But as one of the limitations was that we cannot really provide denominator, or actually incidence rates, as we don't have a denominator. So I found this table doing the preparation of the presentation, and we can see what's the incidence or the estimated incidence for both children and adults in let's say, rare respiratory viruses. And if we focus on the respiratory syncytial virus, which can be found in the upper part of this table, and in adults, we can see how, in general, for hematological malignancy patients, the incidence is around 1 to 12%. And if we go some rows below, we can see that, for example, in the case of myeloma, these rates increase up to 40 or 60%. The rest of the data are regarding children, and since the data of my presentation are in adults, I won't focus on them. But well, we can have kind of an idea that almost 2 in 5 patients, they can get RSV infection every year. Regarding the symptoms, there is actually not so much we can say because they are quite unspecific to RSV, and they are similar to other respiratory viral infections. Based on that, they can be classified as asymptomatic, mild, severe infections, or in case they could get accepted to or admitted to an intensive care unit, one could classify them as critical. So symptoms are not necessarily very useful for the diagnosis of RSV, especially because there the chances, or the epidemiological chances, that the patient is having an influenza or SARS-CoV-2 infection are way higher, and that's what in principle a physician would suspect. It's true that traditionally the seasonality has been used to guide the diagnosis, and in the case of RSV, we can see how it's common, the diagnosis in winter. In the case, this table refers to the boreal or the northern winter, but we have also one problem. I mean, the time or the epidemiological season, it's similar and really overlapping with influenza. So still some additional diagnosis apart from, okay, you are having a cold in December, in January, that's an RSV. So some additional and more elaborated and laboratory-based diagnostic tests would be necessary. And another problem with a problem with the seasonality is that this is not always the same. I mean, it's not fixed in the months I mentioned before. I mean, that's kind of a range. And in this figure, we can see it quite nicely. There are 3 seasons, one for flu in the United States, another one for flu also in Australia, so northern and southern hemisphere. And in the last group in green turquoise, we have RSV seasons for Turkey. In all the cases between the seasons 2017-18 until 2023-24. And specifically about RSV, in the lower part of the slide, we can see how the difference could be, or the range in the peak season could be of around 7 weeks, and that's something that was similar to influenza, and regardless of the hemisphere. In this graphic, these data are from my hospital, the University Hospital of Cologne, and some neighboring countries, in total from a region of 17, 18 million people in Germany. And we can see, we start from above, how this seasonality is also changing between 20 or in the season 2016-17. The peak will appear in January 2017. Afterwards, in the season 17-18, we could see how everything or all the cases were focused only in 2018, and they went up to May. Similar happened, or similar features we could see in 2018, 2019. And then if we focus in the lowest part, we can see how there is a whole missing season. And as you can guess, being the one between 2020 and 2021 that was related to the SARS-CoV-2 pandemic, and especially the protective measures. Speaking about the seasonality, it's also important to keep in mind that the fact that there are several or there are different RSV viruses can also influence this seasonality. Depending on the year and the season, the prevalence of RSV-B can be above RSV-A, or the other way around. And in some years, we can see how one of the types is higher or more prevalent than the other. In the presentation of Francesco, we were speaking about, or in the question and answers, we were speaking about vaccination, and actually one was specifically about RSV vaccination. And in this slide, we have a good summary of what's the situation. In a normal situation, so to say, the people to be vaccinated would be pediatric patients through the vaccination in the pregnant women, and also elderly adults. Here we have the currently available options in the world. Afterwards, we have to pay attention to what's the availability and what are the vaccination programs in our respective countries. I won't go very deep into that because we have the question afterwards. And basically, depending on the target person, we may provide the vaccination or one vaccine over the other one. Regarding the treatment, in the case of influenza, we had oseltamivir, we had guidelines for the treatment and some recommendations. That it's not that clear in the case of RSV, and the gray zone can get quite big. So to say, the recommendations, to use that term, are the ones we can see in the screen. Ribavirin, and we have it in 3 different formulations: aerosolized oral tablets or intravenous, pabilizumab, and also immunoglobulins. We will see afterwards how to use them and what are the specific recommendations. As you can see, one could say that in the management of RSV, we are worse as compared to influenza, but better, in a better situation as compared to other viruses, including metapneumovirus, that will be the topic of my colleague Monika Biernat, or other viruses that will be covered by Barbora Weinbergerova. And on top of that, on top of the specific antiviral treatment, we have to keep in mind that here we are speaking also about patients that receive treatment or symptomatic treatment. So the burden for the whole system is quite remarkable for the whole healthcare system. And here we can observe in this nice review how the impact of RSV in the society and the whole system is quite meaningful, and it can impact, we can see, in productivity, in social activities and relationships, also emotional functioning, physical functioning, sleep or sleep quality, leisure activities, work, and also concentration. I won't go too much in detail in this slide, as Francesco already presented, but here we see again the seasonality with specific data from EPIRESEHA, and we could see how in the whole pool of patients, the peak of RSV happened to be in February 2024. And interestingly, we can see how SARS-CoV-2 was leading leading as the main infective virus until December, and how in the winter season it disappears, and in this case in February 2024 influenza and RSV are the leading causes of infection. Here we can see it more clearly how the peak in our patients in the season 23-24 was in between December and February. Speaking about the main underlying or baseline malignancy per virus, and specifically about RSV, you can see how RSV it's like the 10%, around the 10% in all the malignancies. Of note, we have this one, acute lymphoblastic leukemia, where the patients with RSV are the 16, almost 17%, and it's the second most common virus. And regarding the additional comorbidities, not related to the malignancy, but I mean, in general, we don't see very big differences in RSV as compared to other viruses. The main underlying condition is the chronic cardiopathy, although not reaching 50% of the patients, as it's the case for SARS-CoV-2 or influenza. I mean, here 1 in 3 patients only. And as compared to other viral infections, the second most common underlying condition would be diabetes mellitus, and not really the chronic pulmonary disease. Here we have basically the same presentation, but with statistical significance and the corresponding analysis. I mean, this data will be soon available in a publication, and we could see how the difference between RSV, influenza, and SARS-CoV-2. I mean, as influenza and SARS-CoV-2 are the two main viruses or respiratory viruses, these differences in the underlying condition were significant only in the chronic cardiopathy. And again, speaking about vaccination, we could observe how only 0.6% of the patients with a final infection of RSV were vaccinated against the RSV. I mean, in the question and answers, we can speak about that, but basically it goes in line to what we have mentioned regarding influenza vaccination, including like a physician or treating doctor awareness, but also in the case of RSV, it would be the additional factor that it's the newest vaccine that was made available. And of course, with these vaccination rates, the significant difference, or the difference compared to influenza and SARS-CoV-2 vaccination, is significant. No big differences regarding patients with neutropenia or lymphopenia. I mean, in the case of neutropenia, we could see how the patients with SARS-CoV-2 are significantly or have significantly lower neutropenia levels, which has been described in the literature already. And regarding the symptoms and the severity, I find this slide very interesting and very meaningful, because at the end, we can see how everything is connected, and sometimes we can be in the edge of what's first, the chicken or the egg. So here, if we look in the left section, we can see how the patients with no symptoms, or there were significant differences between RSV and SARS-CoV-2 in the symptoms. And basically, we can see how the levels for no symptoms in the case of SARS-CoV-2 would reach 20%, and in RSV, they stayed very, very low. And regarding the severity, we could see how none of the patients with RSV were eventually asymptomatic. I mean, like, they developed symptoms, or they either needed to be admitted in hospitals. It's true that if we focus on the most right section of the graphic, the number of critical infections due to RSV, which is around 8%, it's similar to SARS-CoV-2, and almost half of those for influenza, and there is no significant difference. But we can see basically that there are patients with SARS-CoV-2, for instance, that can be asymptomatic, or they develop less severe infections, and in the case of RSV, that doesn't happen. So one could think whether there is a problem in the diagnosis. And in fact, we all know that the diagnosis of SARS-CoV-2 is very easy, and even now there are the rapid tests very at hand. Regarding the state during the infection, Francesco already presented some data with that regards. We can see RSV is in the middle of the slide, how these patients are those with the highest numbers of hospital admissions overall. However, if we focus on the admissions to the intensive care unit in light purple, we see that the levels are similar to SARS-CoV-2 and also a bit higher to rhinovirus, but definitely way lower than the infections due to influenza, parainfluenza, or metapneumovirus. And actually, here we can see precisely that, and even if the levels were similar in the page before, in the match control analysis we have performed comparing RSV to SARS-CoV-2 and to influenza, we can see how, in this case, regarding the severity, RSV and influenza behave similarly, and how the patients with SARS-CoV-2 develop less severe episodes in general, and this happens in a significant way. And another difference is the antiviral treatment. We have SARS-CoV-2 with a well-defined treatment approach, also influenza, although sometimes there has been some room for discussion in the administration of oseltamivir. But in the case of RSV, we start seeing how the green section, which is the one of specific antivirals, it's only 15%, which in this case refers to the administration of ribavirin. We have 2/3 of the patients that are the ones in the purple section of the bar that don't receive any treatment at all beyond the symptomatic treatment for the fever, the pain, etc. And this is statistically significant as compared to as compared to influenza or SARS-CoV-2. Still, there are some recommendations and some data coming from real life experience. These data are coming, or this recommendation is from a hospital in Milan, in Italy, and basically they distinguish between upper and lower tract infections, and also based on the EC score, whether it's low, moderate, or high, they make recommendations. They would administer immunoglobulins in any case, and then according to the severity, they would include ribavirin, and in the most severe cases also pavilizumab, which is used also sometimes as prophylaxis. But as I said at the very beginning, or almost in the middle of my presentation, the treatment for RSV is still under discussion in a way, and in this meta-analysis, we can see how the authors, they compare the results for the treatment with ribavirin and focus in different factors. In the first section, we can see how they evaluated the use of ribavirin as all-cause mortality, and only in 3 of the studies they could see how the ribavirin was beneficial. Regarding not all-case mortality or all-cause mortality, but specifically mortality associated to RSV, they could see those results only in 1 of the 3 analyzed studies. When they had the outcome being the progression from upper respiratory tract infection to lower respiratory tract infection, here we have 50%, 3 studies agreed on presenting ribavirin as a protective treatment, 3 against, and also differences were observed regarding the administration route of the ribavirin. Depending on the formulation, the effect could be different. and focusing on this precise access and also or aspect, and also focus on real life experiences. We have this report from the MD Anderson in Houston in the United States, how they made recommendations for both avoiding the progression from upper respiratory infection to lower respiratory infection, and also for mortality. In both cases, the most recommended approach is aerosolized ribavirin together with immunoglobulins, but then we can see differences. I mean, the second option in the case to avoid progression to lower respiratory tract infection is oral or intravenous ribavirin with or without immunoglobulins, and then aerosolized ribavirin alone. In the case of mortality, this recommendation would switch, and the least recommended approach would be the administration of no treatment. Also, once the patient has the infection, I mean, we all know that the lungs in this case get damaged, and that gives the option and the opportunity to other pathogens to develop additional infections or secondary infections. In the case of the secondary infections, if we focus on the type of pathogen, bacteria, fungi, or other viruses, we can see how 1 in 4 or in 5 patients, or the 20% of the patients with RSV, would develop a bacterial infection. Then focusing on fungal infections, that would be only 6%, but in both cases, bacterial and fungal infection, patients with RSV are the ones at the second highest risk for such secondary infection development. And in other viral infections, we could see how the levels are higher for rhinovirus or metapneumovirus. If we make the statistical comparison between RSV, influenza, and SARS-CoV-2, we could see how the bacterial co-infections or the bacterial secondary infections actually are significantly higher in RSV as compared to influenza, and also the secondary viral infections are significantly higher in RSV as compared to influenza. And which are the pathogens behind, or the specific species and genera behind these secondary infections? Well, we have a long list for bacteria in the left section of the table, a long list also for other viruses in the right section of the table, which can be respiratory viruses or non-respiratory viruses, and focusing on fungi in the middle of the screen, we could see some of fungi that basically have, in a way, or are more commonly reported in the lungs, as Aspergillus, Pneumocystis, or Rhizopus microsporus, which is a fungus belonging to the Mucorales order. And then now I'm coming to the end. The difference between the mortality and the attributable mortality. Well, speaking about this, we see how RSV has a lower mortality rate, a lower all-cause mortality rate as compared to other viruses like influenza, parainfluenza, or metapneumovirus. I mean, we have in the middle of the screen how the mortality, or the reported mortality for RSV is 6%. And if we focus in the attributable mortality, we can see how this is also very low. I mean, in the case of influenza, it's almost all the cases die due to, or almost all the patients with influenza die due to influenza, and 50% in the cases of parainfluenza or metapneumovirus. But in the case of RSV, this is way lower. And again, comparing the mortality to, in this case, we have in the left part of the screen the mortality rates for RSV, and in the pyramid in the right for general population and for older adults, we can see how in any case the patients, the hematological patients with RSV, they are at an increased risk for mortality, and they have higher mortality rates as compared to otherwise healthy adult populations, or even older adults that, as we all know, are another population at risk. And this is the case if the patients get admitted in the hospital, if they are medically attended, regardless whether in the hospital or outside, and also in case they develop symptoms. And this slide, we already saw it with Francesco, but here what I want to focus is that the survival probability in the case of RSV is only significantly different as compared to the one of para-influenza. And last but not least, which are the factors associated to the mortality in RSV patients? Well, in this multivariable Cox regression, we could see how the secondary infections are those like more closely related to mortality, or the 30-day mortality in this case in RSV patients, especially bacterial and viral or other viral infections. We have this analysis. This is coming from the very colorful slide I presented before. I mean, from the pool of hospitals in North Rhine-Westphalia, in the region of my hospital, with data from my hospital and also neighboring country. And here we can see how they describe additional factors like admission in the ICU, pneumonia for both day 30 and 90 mortality. In this case, fungal co-infection, but not bacterial co-infection. Fungal co-infection, we can see it in the middle of the slide, and the bacterial co-infection in the bottom of the slide. And also they describe some factors not associated to this, the mortality rate either on day 30 or day 90. So one should keep in mind that even if we read some factors in the literature, at the end our local population may be different from these described or from what is described in the literature. And here some, let's say, consensus between these hospitals in Germany and the EPIRESEHA publication, where no relevance or no association between sex, also allogenic or autologous stem cell transplantation, or the lines of anti-neoplastic treatment are and mortality, and also no significant role of age in the mortality. And last but not least, we have to keep in mind that, as I mentioned, the treatment for RSV is not always clear. The prevention, it's not always implemented, the vaccination. So these are the associated costs to influenza, to RSV, and to SARS-CoV-2. And we see how the values for RSV are lower in general as compared to the other ones. And basically, what I want to point out here is that if we would pay more attention to the management of RSV, these values could get even more reduced. So with this, and this is the very final slide with my presentation, I want to share the conclusions. And it's basically that despite RSV can be less severe than other respiratory viruses, with lower incidence or different severity, RSV still significantly impacts patients with hematological malignancies. And this leads to high rates of hospitalization and also ICU admission. And we are speaking about a virus that, unlike the ones that will be presented after me, we have a vaccination. There are options for early diagnosis, and we probably should pay attention in there, and also in the individualized treatment. And all these are essential to reduce the RSV associated morbidity and the mortality in a high risk population as they are the hematological malignancy patients.
Thank you, John. Very, very nice, very, very complete presentation. And you can help us to raise a lot of questions. I have the first for you. Considering that there is a large number of patients that can develop RSV, and considering that for our lucky, the mortality rate is not high, if there is, of course, no comorbidities, co-infection, co-bacterial infection. is indicated for all patients the vaccination or not? Or we must identify a group that probably needs better than others of a vaccination?
Yeah, not really. I mean, it's more focused on basically what we were mentioning before in the case of influenza, that you have um, to focus on specific patients and actually also on how it's the let's say the correlation between the in this case RSV vaccine and the specific hematological malignancies. I mean, I didn't include in the presentation, but another time that I presented also RSV in hematological patients, I came up with a nice publication where they were describing how the effect of SARS-CoV-2 vaccine was different depending on the hematological malignancy. So probably that would be one of the ways. And also, as it was mentioned before, not only the physician or the medical team awareness, also the awareness of other members of the treating team. I mean, like of the healthcare workers. I mean, in Cologne, we made a couple of publications on there on how relevant that is, but also on the availability and the interconnection between the different physicians and hematological patient sees. I mean, like in the slide I presented on the vaccination, we could see how the rates for SARS-CoV-2 and for influenza were also very low. I mean, like the highest one was for influenza and it was 11%. And of course, it could be that the vaccinations were very low, but we also associated such a low vaccination rates to the fact of lack of information and communication between the different steps, like the general practitioner and the specialized treatment. So yes, it's a matter of targeting the patient, but also the problem, so to say, it's a bit wider, and we should look at all the ages of such a problem.
Brief question, brief reply. You are longer, please.
Just a consideration from my side. I can make myself visible. I don't know why, but it's not a problem. Just a consideration, John. I think that here the vaccination is more important than right. It's still more important than influenza because we have ribavirin, yeah, but we should keep in mind that ribavirin is not available in all countries, and at least in Italy, it's off-label. So we can treat the patients with ribavirin without asking for a ethics committee. It's not an indication.
Yeah, I mean, that's also one of the things with RSV vaccine. It's quite recent. I mean, it's been in general, and that's why I was speaking about the availability in the world, because still in some countries it's not available. And yeah, I mean, it made available for the first time in 2 or 3 years ago.
Okay.
Judith, you have a question?
Yes, I do. Thank you very much. I'm Judy Brewer. I'm Professor of Virology at UCL in London. And we're using experimental combinations of RDRP, dependent RNA polymerase inhibitors in our patients. And I'm just very aware that we really need to have proper platform, adaptive platform clinical trials in these patient groups with sufficient numbers that we can actually just start to plug in. I mean, there's lots of anecdotal sort of, quite good quality anecdotal, but still anecdotal data on what works and what doesn't work. But what we really need are these large scale adaptive platform studies. Are there any plans in the European sort of community of here to start such trials and start considering potential drugs that we could plug into those?
Well, maybe I can say something. I fully agree. I see exactly the need. It was impossible to convince the European, the EU, let's say. And we had the Accelerate program until January, where many sites throughout Europe were part of, including the UK. And and the funding was stopped. So what we did towards the end, because that is exactly what we proposed to have an adaptive platform trial, we wrote the protocol. Okay, so we just did it on our own. And we are now looking for funding. So as soon as we have a first company or whatever vaccine developer who would allow us to or fund us to create a first subgroup, then we would be there, because it would be much cheaper than for the second, third, and fourth to come on board. So we are ready to start. The protocol is there, and we can adapt it to whatever respiratory pathogen is out there. We can adapt it within a week. If it were influenza, we don't need to adapt it, because that's the example we wrote it for. And you have to have something that you write it for, right? So yes, please, let's stay in touch. And
do you have a link that you could put in the chat? Do you have a link you could put in the chat so that we could, those of us who don't know too much about this, could actually start to make contact with you?
It's basically, I would add my email address to the, which might be easiest. And yeah, so.
That would be marvelous, because I think we're desperately in need of these trials.
Absolutely.
And there's lots of good work going on in lots of different places, but we need to actually.
And if there is finally a fitting call where we could apply, then we need an international consortium, usually quickly. And why not? That should be born from the group in this call today. Yeah.
Fantastic.
Thank you very much for that. Really helpful.
Okay, Oliver, no question again. So I think that we move from the next, please.
Yes, we move to the next speaker. That's what we do, and to the next virus. So the virus is human metapneumovirus, and it was here and there hMPV on one of the other on one of the slides that we already saw. But now it is not a side dish. Now it's the main dish in the next presentation, and that will be given by another of our core experts, and that's Professor Monika Biernat. She's a assistant professor at the Department of Hematology at the Wroclaw Medical University in Poland. And Monika, floor is yours. Thank you for being with us today.
Thank you, Livio, for kind introduction. I try to share my screen. Can you see my presentation?
Yes, we can see the screen, and now we are in projection mode. Fantastic. Thank
you. I'm very happy to be with you today, and I would like to share some insights into characteristics of this virus, because it's not so old virus. We know it since 2001, when it was discovered on cell lines from isolation of 28 children, Dutch children, during the outbreak. Because I'm hematologist but also microbiologist, I would start with some general introduction of this virus. Human metapneumovirus, as similarly as respiratory viruses like influenza virus or RSV virus, infect upper and lower respiratory tract and typically affects young children, older adults, and individuals with weakened immune system, including hematological patients. This is enveloped single-stranded negative sense RNA virus, member of the metapneumovirus genus, and it's coated by envelope, which consists of 3 proteins: fusion protein and glycoprotein, and they play crucial role in attachment to the epithelial cells of the host, and also starting initiation infection. And also S8 protein, which is in inner surface, but it acts as a bridge between envelope and nucleocapsid. Genome includes 8 genes, which encoding these 9 proteins. And virus interferes with host immune system using specific mechanisms. Specifically, it may lead to a minimal and late immune response and delayed cytotoxic T-cell activity with impaired virus clearance during primary infection. So it triggers a strong pro-inflammatory response, which characterized by a release of cytokines like interleukin-6, TNF-alpha, chemokines, and adaptive immunity plays crucial role by production of neutralizing antibodies and T-cell response. The virus induces airway hypersensitiveness and enhances mucus production, which is very, very typical sign for this infection. And it can result in airway obstruction and exacerbation of symptoms in patients with some comorbidities, like asthma, like chronic obstructive pulmonary diseases, and some other diseases of the lungs. Virus has two major genotypes, A and B, which circulate worldwide in many different continents. Each genotype is divided into two subtypes, subtypes A and B, which are based on some differences in sequences of attachment protein and fusion protein. Since it has been reported and discovered, there were 15 outbreaks reported worldwide, 5 in Europe, 4 in North America, and 6 in Asia. It is supposed to be second leading cause of mortality among children, small children, irrespective of geographic variations. About 15% of community-acquired pneumonia cases required hospitalization in small children. And the prevalence of infection among adults varied about 3% to 7% across mainly winter seasons. And this statement is similar and very comparable with our reports based on EPICOVID-IHA report. The rate of hospitalization in respiratory tract infections in adults older than 50 years or above is about 4.5. So the main risk factors are weakened immune system. It's highly prevalent in some transplant recipients, mainly lung recipients, age older than 65, and immunocompromised hosts, mainly receiving immunosuppression. Also, some chronic respiratory conditions, as I said before, plays crucial role in the type of course of infection. As we look at clinical manifestations, symptoms typically develop in about 3 to 6 days after exposure, and we can observe symptoms from mild, like cold-like symptoms, to severe pneumonia, and also acute respiratory distress symptom. So symptoms are mainly identical as in RSV virus, and common symptoms include cough, fever, which is most common, much more common in case of human metapneumovirus, sore throat, and some other typical symptoms of upper respiratory tract infections. We can observe also high blood temperature, hypotension, and high respiratory rate. Leukopenia is another risk factor for lower respiratory tract manifestations. In case of pneumonia, we observe cough, shortness of breath, and much rarely chest pain. And also, we can observe some other symptoms which are not typical for mild symptoms. We can see in case of upper respiratory tract illnesses, but we can observe them, for example, in case of influenza. Similarly to that, in patients with this virus infection, we observe muscle pain, some joint pains, and headache. If we look at some radiological features of metapneumovirus infection, usually the signs are bilateral in chest X-ray, and we observe patchy consolidation. In CT scans, bilateral signs are also very common, and usually we can see ground glass opacity. But what is worth to point out, normal chest radiography doesn't rule out pneumonia, particularly in early stages of disease. And signs in CT scans may mimic bacterial infection. But we look at the report, which was nicely presented by John, considering new metapneumovirus, it was much prevalent in case of patients with chronic myeloid malignancies and also in case of MDS. The prevalence of infection was about 30%. Mortality rate was and overall, survival probability was much better than in case of SARS-CoV-2 or RSV, but this overall survival, about 30 days, was also lower than in the course of onset. As it was said before, we use PCR method, usually multiplex PCR method. And of course, in case of lower respiratory localization, we endorse using low dose chest CT. It should be pointed out that we do not have specific treatment, antiviral treatment for this infection. We usually use general supportive care, some oxygen therapy, and in case of deterioration of symptoms, we should use mechanical ventilation and sometimes ECMO. There are some conflicting results about using ribavirin and also immunoglobulins. It's important to say that, as John showed us, metapneumovirus can co-infect patients with RSV virus, and this critical illness was seen in our report in about 14% of cases, and about 14% of cases needed ICU admission. Also, some comorbidities, including lung involvement, deteriorate course of illness in case of this virus. In very severe cases found in literature, ribavirin was co-administered with corticosteroids and immunoglobulins. There are some case reports about using of ribavirin in this case. Also, there are some early clinical data about use of probenecid, which is inhibitor of host transporter. But there are some few reports about some other drugs. Also, in contrast to RSV virus, where vaccine is available, we do not have no specific vaccine. In January last year, some new mRNA vaccine candidate was developed. However, it's in early clinical trials. So we should use some infectious control measures. Mainly, we should remember that this isolation is the crucial point in case of our hematological patients, because in such cases, there are some prolonged viral shedding, similarly as in case of SARS-CoV-2. What is also very important to know that this virus can survive for several hours on some superficial surfaces. And this also may lead to indirect transmission. So to conclude my short speech, metapneumovirus can cause mild symptoms of upper respiratory tract infection, but also may manifest as severe pneumonia and ARDS. It's re-emerging respiratory pathogen, which is responsible for significant morbidity and mortality, especially in our group of patients. This mortality rate in our report was about 3.7%. And what is also very important to know and to remember, this virus should be included in differential diagnosis for patients with respiratory tract symptoms, especially in our setting. Thank you very much.
Thank you very much for, well, introducing sort of hMPV to us. We know that it's out there, but we didn't really pay attention in the past, I would say. And maybe that was only the case in Cologne, but I guess elsewhere as well. So we do have some questions here. And one point is, what conclusions do we draw from the data? Treat all hematological patients with ribavirin and immunoglobulins in case of respiratory viral infection? Question mark.
In about 50% of cases in our report, including RSV and metapneumoviruses, except for influenza and SARS, were not treated at all with some drugs, antiviral drugs, or in about 10-15% of cases of more serious infections, considering metapneumovirus, we use corticosteroids and some supportive care.
Yeah. Okay, so I would say no, we don't treat all of them, right? But so agree with what you said. Francesco, you have a question, and
Yeah.
Livio, well, whatever, both
Before
of you will.
Francesco, please.
Yeah.
Okay, just a curiosity for Monika from a hematology perspective. So we saw that metapneumovirus is more prevalent in patients with chronic malignancy, chronic myeloid malignancies. Do you think that it is, just random for the low numbers we collected, or there is a room for a rationale here?
Yes, it's quite interesting observation. I think it may be, yeah, we need some more data, but I think there are some patients with some symptoms of lower respiratory tract in course of TKI treatment, and maybe it could be associated with that they are some pleura and some fluid in the lungs, and maybe it can increase the risk of such infection.
Okay, thank you.
A provocatory question, Monika. If at present we have the possibility to vaccinate these patients, our patients, all patients with hematological malignancy, you vaccine for this kind of virus infection?
Yes, this is a very provocatory question. So we should observe the population after RSV virus vaccination, because they share some common features, these two viruses. So, of course, I won't say that it fully protects against metapneumovirus, this vaccine, but I think the prevalence is low. It's important to use some precautions measures and see, but I would say maybe some transplant recipients, not all patients.
Perfect, thank you.
I was muted. So that is hypothetical, right?
Yeah, it's very hypothetical.
But there is so like for many other viruses, there is a vaccine in the making, so to say, and maybe we will see something during the next, not 10, but much lower number of years, a vaccine directed to hMPV. That would be pretty cool, I guess. And if that were the case, then the data that we collect together will be even more important because we already have the highest number of hMPV patients in the registry, way more than you would find in the literature. And so just another advertisement for joining and for entering cases. If any advertisement is needed. Thank you. I don't see another hMPV question, but others in the group checked as well so that I don't overlook one, I hope. And with that, I say again, thank you very much, Monika. There's Per Jungmann. Per, please unmute and
Yes, I'm trying. Hi.
Hi. Perfect.
Thank you.
Good to have you.
Thank you very much. I think when we are discussing these very heterogeneous populations that both John talked about and now Monika talked about, and that's why I was so interested in your clinical trial platform that you can think about plugging things in. I think there's been so many uncontrolled reports on, for example, ribavirin, take it as an example, and we are certainly part to blame in that because we have published some ourselves. But to really know if there is any effect, we need to do a proper randomized controlled clinical trial, which is extremely difficult. Michael Buck and the Seattle group tried to do it for RSV, and the inclusion was so poor that they had to close the trial because everybody just thought ribavirin worked or didn't. Now I don't think necessarily the next trial should be with ribavirin, but whatever new thing is coming up, it could be RSV vaccines, it could be hMPV vaccines, it could be a new antiviral, monoclonal. We really need to do a controlled trial.
Mm-hmm.
Yes, totally agree. Yes, we need to know more. And what is important that in fact we've got more specific, much better tests, assays as before. So we are able to detect this virus. Before we didn't know that it even exists. So we should observe, but not necessarily treat and use vaccine against it. We need more data.
Okay, so again, thank you very much. And we switch gears and move on away from hMPV to, well, that's special, to other viruses. So that sounds like a whole bunch of viruses and another difficult topic, but I'm sure that one of the top experts that we could win for today will master this task. And it's Professor Barbora Weinbergerova, head of the group of opportunistic infection and immunocompromised patients, and from the Faculty of Medicine at the Masaryk University in Brno in Czechia. And Barbora, thank you very much for being with us. Please share the screen. It's all yours.
Share my screen. Yes, do see. Can you see my presentation?
Perfect. Thank you.
Yes. Okay. So I will... Yes. So good afternoon, dear ladies and gentlemen, dear colleagues. First of all, I would like to sincerely thank the organizers for inviting me to this webinar, which I greatly appreciate. My name is Barbora Weinbergerova from Masaryk University Hospital Brno. I focus on opportunistic infections in immunocompromised patients, and today I will be speaking about other respiratory viruses in hematology that previous speakers did not talk about in detail. So let me start with a brief overview. First, I will provide some background to set the stage, then we'll focus on the main community-acquired respiratory, other community respiratory viruses of interest, and discuss their risk factors, diagnostic and treatment. After that, I will briefly recap findings from the EPICOVID and EPIFLUEHA study, because previous speakers talked about this study a lot, followed by our own case report to illustrate clinical relevance, and finally we'll summarize the key take-home messages. So, respiratory viral infections are a major complication in hematology. Beyond the classic viruses, influenza, RS virus, and metapneumovirus, a broad group of other respiratory viruses, including parainfluenza, adenovirus, rhinovirus, seasonal coronaviruses, and SARS-CoV-2, contribute substantially to morbidity and even mortality. Thanks to a multiplex PCR, detection has increased, revealing how frequent and clinically relevant these infections really are. However, we still face the same challenge. There are no specific antivirals for most of them. Prolonged shedding, treatment delays, progression to lower respiratory tract infection, and nosocomial spread are all common in these infections. Mortality may range between 10 to 40%, depending on virus type and the degree of immunosuppression. So, parainfluenza virus is RNA virus of the Paramyxoviridae family, with the subtype 3 being the most common type in hematology patients. Incidence ranges from 3 to 7% in hematology patients, and this pathogen is frequent but probably unrecognized. While immunocompetent hosts experience usually mild upper respiratory tract infection, in immunocompromised patients, we often see prolonged shedding and progression to lower respiratory tract infection. Severe pneumonia develops in up to 30 to 40% of highly immunosuppressed patients, for example, transplanted patients, and mortality may reach up to 35% in regarding hospital-acquired pneumonia. Adenovirus is a DNA virus with more than 50 serotypes. It can establish latency in lymphoid tissue and reactivate post-transplant. The main risk factors for adenovirus infection is represented by T-cell depletion, graft versus host disease, haploidentical donor, and severe lymphopenia, and others. Adenovirus often disseminate mainly in pediatric population and in allogenic transplanted patients. PCR monitoring in blood is strongly recommended to detect early viremia. Rhinovirus. Rhinovirus is the most frequently detected respiratory virus by PCR in hematology patients. It typically causes only mild upper respiratory tract infections, but may lead to lower respiratory tract infection, to severe infections, mainly again in highly immunosuppressed patients, especially transplanted patients. The interpretation is challenging because PCR often remains positive long after symptoms resolve. And again, also in rhinovirus, we have no specific antiviral therapy. The 4 endemic coronaviruses usually cause mild upper respiratory tract infection in the general population. However, again, in immunocompromised hosts, they may lead to pneumonia or co-infections with bacteria or fungi. Prolonged shedding or reinfections are frequently reported in immunocompromised patients. And again, there is currently no specific antiviral treatment available. Now, briefly about COVID-19. This slide summarizes how COVID-19 has evolved in hematology from the high mortality early phase to today's endemic yet still relevant infections. Omicron variants dominate with shorter incubation and milder disease, but immunocompromised patients remains vulnerable with prolonged shedding and a risk of reinfections and still with a high rate of mortality. Importantly, COVID-19 can overlap with invasive fungal diseases, and we know COVID-19 associated pulmonary aspergillosis or mucormycosis with a high rate of mortality above 40%. So what are the main risk factors of a severe course of these infections? These are lymphopenia, prolonged neutropenia, high-dose corticosteroids administration, allogeneic transplantation, GVHD, CAR-T therapy, and patients with chronic lung disease. And bacterial and fungal co-infections may further increase or decrease patient survival and outcomes. Diagnosis relies on multiplex PCR panels from nasopharyngeal swabs or bronchoalveolar lavage fluid. This is now the gold standard for diagnostic of these viral infections. For adenovirus, quantitative PCR helps monitor viral load and correlates with the risk of progression to lower respiratory tract infection and dissemination. Radiologic findings are usually in these infections non-specific with bilateral or ground glass infiltrates on CT scans. Unfortunately, as we mentioned earlier, we have no approved antivirals for most of these infections of these viruses. Ribavirin, as you can see in the table, has been tried for para-influenza virus, but the results have been inconsistent. For adenovirus, in some cases, we can use cidofovir, and the therapy we guide by PCR results, hence supportive care, including oxygen therapy, reduction of immunosuppression, and empiric antibacterial coverage remains the cornerstone of management. Strict infection control and early isolation are essential to prevent nosocomial transmission. Finally, in transplant recipients with severe respiratory infections, we can use adoptive virus-specific T-cell therapy to restore antiviral immunity. And of course, for COVID-19, we use antivirals like remdesivir or nirmatrelvir-ritonavir that improved survival of our patients. And active immunization continues to be the cornerstone of prevention of severe courses of this disease. So now let me briefly recap the results from EPIRESEHA EPIFLUEA collaboration from this study. As previous speakers mentioned, it included more than 1,300 hematology patients with respiratory viral infections. The most common was SARS-CoV-2, following by influenza. I will not repeat the results that have been mentioned, but I would like to emphasize that this study confirmed that para-influenza virus occurred only in 2.4% of all infections, but these patients had the highest mortality, reaches over 20%. So we need more data and more detailed analysis on para-influenza cases to do, and I can say that we plan broader analysis on this theme on para-influenza virus cases from EPIRESEHA. So now at the end of my presentation, let me introduce you our own case of para-influenza virus infection. This was a 20-year-old male with a high risk of acute myeloid leukemia, early relapsed after haploidentical transplantation. We administered to him immediately salvage chemotherapy in regimen venetoclax plus HAM. And early after the end of the salvage regimen, he developed cough, and we diagnosed by PCR para-influenza virus infection from nasopharyngeal swab. We treated him only by supportive care, supportive therapy. And on the chest CT, you can see his scan here. He had only minimal peripheral pulmonary infiltrates. After that, he developed a lot of infectious complications, but finally the patient status improved, and we discharged this patient home. But as you can see here, there was a prolonged PCR positivity of para-influenza virus subtype 3 in this patient, lasted more than 6 weeks. After his second haploidentical transplantation, he early developed a septic shock, which we treated by broad-spectrum antibiotics and granulocyte transfusions. On his chest CT, after a couple of days, we could see a progressive pulmonary infiltrate, so we added preemptively lipid formulation of amphotericin B ambisome. No bacterial or fungal pathogen was identified in this patient, and unfortunately, bronchoalveolar lavage was not feasible to perform because of the patient's status. He had respiratory instability. Subsequently, the patient developed other important and difficult complications. GVHD, which we treated by high-dose corticosteroids plus ruxolitinib, and also BK virus cystitis, which we treated by infusion of BKV-specific T cells. It is important to note that at that time, acute myeloid leukemia in this patient was in a second complete remission, but the patient status was very severe. He was prolonged, profound pancytopenic, and had severe renal failure on continual hemodialysis. As you can see here, we examined this patient for parainfluenza virus again, and after 3 months, he was again positive by PCR. So it was probably chronic infection, chronic parainfluenza infection in this patient, or he reactivate under profound immunosuppression. So during follow-up, the patient developed progressive pneumonia. You can see the following CT scan here, and we diagnosed probable invasive pulmonary aspergillosis. It could be associated with this parainfluenza virus. We don't know, because at that time we didn't examine, for example, viral cultures to know if it is active parainfluenza virus infection. So we added isavuconazole to this patient, but despite all of our efforts, the patient died in a couple of days due to terminal bronchopneumonia and multi-organ failure. So to conclude, adenovirus, rhinovirus, seasonal coronaviruses are all important viruses, but I would like to emphasize that parainfluenza virus warrants keen interest. It is underestimated pathogen with high risk of progression to lower respiratory tract infection and with a higher rate of mortality. PCR diagnostic is essential for diagnose this pathogen. We have no antivirals. We have to prevent this infection, and prolonged shedding in immunocompromised patient is common for these other respiratory viruses. We need urgently research into viral infectivity and replication kinetics in long-term shedders, for example, virus culture and other methods. And we need also multi-center data to analyze, to know, to understand parainfluenza virus infection and to improve outcomes of our patients. At the end, I would like to thank all participating EPIRESEHA centers, my colleagues, data managers, patients and their families, and also to microbiology and virology collaborators. Thank you very much for your attention, and I am very happy to receive your questions and to answer.
Thank you very much. Thank you so much. And a wonderful fourth presentation. This is a good meeting, right? So time is moving, but we don't feel it. That's what I think. It's not a single boring second here. So, and we have still more than 100 participants. Fantastic. So that tells us there should be quite some questions, maybe to the whole family of viruses that Barbora, you just introduced us to or reminded us of. With an instructive case on top. And there's even people asking for that the case might be shared, but it's part of the recording anyway, so everybody will receive that link. And so happy to take questions. I see that Per Jungmann, that you are, you may want to start, please.
No, I think this was very interesting, and I completely agree that parainfluenza is a pathogen that probably needs even more attention than the other we have discussed. Our experience certainly not good. Just a general comment, and that is that we probably can scratch adenovirus from the list. In the first place, it's not really a respiratory pathogen. at least in transplants, it's more a GI pathogen and a systemic pathogen, and hopefully will actually get an effective antiviral, because the phase 3 on brincidofovir IV brincidofovir is finally starting more or less as we speak. So, but otherwise, I completely support the interest in the parainfluenza viruses.
Thank you very much, Barbora. It's your commending
Yes,
your talk, basically.
I completely agree. But we can also diagnose adenovirus from respiratory tract samples. So maybe we can say that it belongs to respiratory viruses also, and it is highly important pathogen, especially in transplanted patients, especially as I mentioned, in patients after haploidentical transplantation and mismatched transplantation. So I completely agree that parainfluenza need more data and detailed analysis. So that's why we plan to do this. Thank you very much.
Thank you. Livio?
Yes, I want to underline the importance of a registry as the hour in order to better knowledge of all these viruses that probably we see, but we under-evaluated in the outcome in the treatment. The importance to have more data and I think that also in the next winter we must perform a similar survey in order to have new robust data to see if there is the difference, considering also that at present we have a lot of new immunosuppressive drugs, biclonal antibodies against for myeloma and lymphoma, CAR-T. We have also treatment for chronic lymphocytic leukemia that can cause relevant immunosuppression. I think that this kind of complication will be more frequent and more important. So an early identification in order to support these patients remain a very important point. And the epidemiology represent always the most important, the first step in order to move in the treatment of these patients.
And I think it's important also to point out what Barbora showed, that this case perfectly showed that progression of baseline disease is very important risk factor for severe types of infection by our viruses.
Yes, and very important is what I mentioned to know if prolonged viral shedding means active infection, or it is only shedding of DNA or RNA of virus, and this infection is not active. So it is very important to provide viral cultures or any other method to recognize or to find out, if it is active infection.
And it does have its infection control implications, right? So if it's just parts of the virus, then you are relaxed. If it's infectious, then you are in big trouble in your hematology unit, right? And may see an outbreak. Yeah. So we are happy to take more questions from the floor, so to say. While we do so, we have the one or the other that was not yet addressed because it was asked not at the right point, so to say, so that we saved it for the end discussion that we are now entering. And one question, John, that I would have to you, because you are likely counting them. What is the number of publications that we have in EPI-COVID, EPI now EPIRESEHA so far? Because we have these massive numbers of patients in the registry, so that we do that we are able to report on sub-questions and subpopulations that are more homogeneous than the entire thing, where there is, of course, a lot of different underlying diseases. So what's the number of publications so far?
Yeah, so far we have 27. I mean,
Yeah.
27 already published. There are 2 to come in human metapneumovirus and in RSV. I mean, like separately, and also in other viruses. And we are also preparing one in secondary fungal infection after after the respiratory viral infection.
So
But yeah, I
soon
mean,
30, and with a lot of authors. So because everybody who contributes will find his or her name on there, and if you contribute lots, then you will speak at the webinar. It's like so. Please consider coming on board. It's as Francesco made that point at the very beginning. This is not a closed shop, but we always look for more collaborators. And then we find, surprisingly, all of a sudden, a lot of hMPV or RSV or other pathogens. I'm sure we could write a paper on parainfluenza. And no, I don't see a cat, do I? It's not a virus.
Also, she is interested to do our studies. Also, she wants to collaborate with us.
Wonderful, yeah, no objections. So, and quite some of these pathogens are zoonoses, right? So it makes perfect sense. And quite some of them are systemic infections. So Professor Lungman made that point on parainfluenza, but it's true for others as well. We actually know that it's systemic infection, because if we have influenza, then we feel bad not only in the respiratory tract, right? And that is the case for quite some other pathogens. And for some, we only start to realize. And if we go back, COVID, we thought, oh, it's respiratory. But then pretty soon, but not at the day one, we understood that it's really a systemic disease. John, there was one question on the secondary infections, and I think we didn't address it. And was that well, it must have been RSV, because you were asked, right? So secondary bacterial infections on RSV, question coming from Hong Nguyen, and whether it's more gram-positive or more gram-negative, or whether you can roll a dice. That is more or less how I would recap the question.
Yeah, I mean, that's a very good question. And actually, it's nothing that we are, I mean, that it's in the plans of answering with a new publication. So maybe it's we can use it somehow as a call of attention to ourselves. I've been checking the literature, and there is not really any big preference, so to say, or like a big prevalence between one or another. I mean, like, the most common ones might be Streptococcus pneumoniae, which is gram-positive, or Staphylococcus aureus, which is also gram-positive, but in the gram-negatives, Haemophilus influenzae. I mean, it also depends on the type of patients you are having. I mean, like, if they are young, old, also if they how at high risk they are. So it can be very, very variable, the topic, and yeah, I mean, actually something we could describe, because there are indeed many patients with such secondary infections.
So that tells me we need more cases, because then we can finally see a pattern. But maybe we'll never see a pattern, but at least we would be, well, even that would be interesting if the number is even higher in the denominator. Thank you. So Dr. Anika Naz, I hope that was correctly pronounced, please.
Yeah, my name is Anika, and I want to ask, like, as you earlier mentioned, that the secondary infections are more important to address on time, right? So is it possible that according to the surveillance, or to improve the mortality rate, to lower the mortality rate, to reduce this phenomena, we can first address the secondary infections rather than to just think about directly for the viral action. I mean, because it will, take some time to address some issues related to the secondary infection, because we have to wait for the lab reports and the other factors to improve the patient's outcome.
Okay.
Okay, so sorry, can you hear me
So
clearly?
who should reply to your point? Yeah.
Right. Okay. Because it's more problem in the developing countries rather than in the developed one, because in the developing countries it's like
Yes.
takes too much time to wait for the reports and
Yeah. I understood, yes, and I understand. And there is a very similar question in the chat, actually, from our colleague Precious Nguira, which is about how robust is so is it a problem in settings where there is no testing being done, or laminar flow device, maybe that is available, but only for COVID or something. So, but not for the spectrum of viruses that we were discussing today. So I'm sure the problem is there as well, and it's underdiagnosed and it's underestimated, underappreciated. I'm very sure, because that is exactly what it was before we started testing. And we started testing because of the pandemic. We test even more. And we did not test enough before. We had smaller panels and a lower threshold to go for testing. And so the more tests are being done, the shorter will be the turnaround time in these things, but it's like a hen and egg thing. So the problem will be there, but you cannot size it right now, I guess.
So are you, is this forum is open for the new projects or the like input of the people from the developing or, less developed countries?
We are always open for input. The thing is, we do not have any budget. So the whole COVID and EPIRESEHA was basically done without budget. So with the spare hours, with the Sundays of if there were any left over of Livio and John and me and Francesco and everybody else. So everybody else, a 3-digit number of people documenting their cases. Yeah, but feel free with suggestions to reach out, ideally to John, Livio, or me. I would offer. Thank you very much. Thank you.
Thank you so much. Thank you. Nice to talk to you.
Additional questions. So is there pathological confirmation? That's a question to the entire. I would say no in some years, but usually not. It's not what you clinically do, right? That would mean histology, I presume, and whether there is a special kit. Well, it's different kits and different PCRs being done, and in different places, I would say. John, you may want to comment on this, or Livio, I see you shaking your head, so maybe.
The point is that probably, as we already said a lot of time, this is under-evaluated and underestimated. So there is a low interest. The point is to increase the interest. Because increasing the interest, showing that there is a problem, there is a risk for the patients, probably we have at our disposition in the future more detailed tests for this, for identifying these viruses. As is happened for fungal infection. The example of the lateral flow that represent a meteor, but it's important because there is an increase of fungal infection, and we focused our attention on fungal infection. If there is no interest, there is no interest also from the company to develop tests in order to improve the identification of this kind of problem.
I would say we don't have a special kit. It is possible, basically. But we do have right now a list of pathogens we need to test in hematologic malignancies patients. And that's we published on SL10 guidelines on Lancet infectious disease. So we do have a list of viral infections we need to test in our patients.
That is true, but it's a difficult thing to do in all the different settings. We have our participants here from, as you can see from the chat, from Malawi and from other countries where there are less options, I guess, to choose from in diagnosing and treating. The one test that comes to my mind, and we just published a paper on this, I almost forgot to mention it, is a test of the a lateral flow device, like the usual COVID tests that we run all the time or did run all the time. A lateral flow device where there are 5 pathogens on there being reliably detected, which is influenza A and B and RSV, adenovirus, and of course SARS-CoV-2. But even that test, which might come at, I don't know, €2 or something, is likely way too expensive for some settings. So specifically if you would repeatedly do it. But so that might be something where the turnaround time then basically is 15 minutes because you just read it the same fashion you read your COVID tests. Just comes to my mind. So there's another question, and then we will slowly come to an end, I believe. And Livio, I will leave it to you to close the session because I opened it. Okay. So, but we have one more question here. I just read it. The time before COVID-19 and after COVID-19. Yeah, that's BC and AC, right? Before COVID and after COVID. Do you think that the numbers of respiratory viral infections increase despite the awareness, knowledge, testing becoming regular procedures? So that's part one. So do we think that there is a change in epidemiology, or is it just a change in testing? That's how I understand the question. And I don't know who wants to answer.
I think both.
Yeah.
Now we have more attention for viral infection in our patients.
Yeah.
On the end. On the other hand, as I already said before, I speak as a hematologist. The new treatment that we perform, causing a more deep immunosuppression, and above all in lymphoproliferative disorders, favor the onset of this kind of complication. So on the end, we have more attention, probably because COVID opened the Pandora basket, and so we know that there is also viral, near bacterial and fungal infection in our patients. And on the other hand, we have an increase for the treatment. We arrive to treat patients with myeloma, with the lymphoma, with 3, 4, 5 lines of treatment. So the immunosuppression become very important in this kind of patients. So both the situation is not only a cause, but various.
Thank you very much. And it is what answers the question. So we got approval, so to say, for my interpretation of the question. Thank you very much, Livio. And well, I hand back to you, Livio. Please.
Thank you, Oliver. Thank you for your presence and the presence of all these good speakers that I think help us to clarify the situation. Now, as I already said just a few minutes before, we have the idea more clear. And I hope that this webinar could be useful for everybody in order to understand some more information on this kind of infection. And I invite all of you to participate to our epidemiological study, because more data we have, more information we can give you in order to a better approach in the clinical practice. Thank you, Monika. Thank you, John. Thank you, Francesco. Thank you, Barbora. And above all, thank you, Oliver. Good evening, everybody.
Good evening.
Thank
you very much.
Thank you very much.
Bye.
Thank
Thank
you.
you.
Bye-bye.
Bye.
Good.